Looks like we're good here. Thank God for the movement break. I'm usually really sleepy after lunch, so I'll try to keep the energy going. Thank you very much for inviting me here. It's a pleasure to speak to the members of the community. I came to Windsor in 2019 from Toronto, where I lived for 17 years, but I actually grew up in Kitchener. And so to speak to a group of an organization representing Southwestern Ontario is a real treat. So I was trying to figure out what to speak about, and I don't really do research in Parkinson's disease per se, but I thought, you know, maybe one of the things we can do is we can just talk about what a neuropsychologist does and what cognition is all about, and just sort of kind of keep it nice and light. But then I looked through some of the studies that are going on in my lab, and I actually do have some things to talk about. So I'll go through some studies, a few of them, and these are kind of preliminary things, hot off the press, so don't tell anyone else. But I thought I'd share some initial findings, some research that's ongoing to kind of pique your interest. And then we'll sort of close off the day. Does that sound okay with everyone? All right, I'm going to try and speak at a decent pace, but if I'm too fast or something, someone just please put your hand up and pretend you're honking at me or something, and I'll slow down, okay? Before we get going, I have no financial disclosures or conflicts of interest. I am a psychologist, and we have a training program at the University of Windsor, so I do assessments, but that's through my role as a trainer, not as like a practice. So I thought I'd start off talking about how we think about cognition as someone who studies cognition, who studies memory and different things. And this is something we're all kind of interested in a little bit, but sometimes it helps to have a framework to have a better understanding of how these things are parsed apart when we study these things in a laboratory. So I'll be using a lot of terms that are familiar, but maybe the way that I describe them might be a little bit different. Okay, so the first ingredient or aspect of cognition I'm talking about is attention. To give you the general Coles notes, we can talk about attention in three ways. Selective attention, divided attention, and sustained attention. A selective attention is exactly what you think it is. We are constantly bombarded as human beings with all sorts of information, some of it visual, auditory, taste, smells, even touch, and our brains cannot keep track of all of it at once. We simply don't have the processing capacity to do so, so we have to choose. And that's what selective attention is. And as a general principle, there's two ways that we select attention. Either we select something in our environment based on a goal that we have, something within us. Let's say I was trying to find my friend in a crowded room, and I know she's wearing a red hat. I would have to go and look for something red, and hopefully that would help guide or select what I pay attention to. However, as you all know, sometimes things just grab your attention, whether it's a loud bang, or a police siren, or a really loud or a bright flash. There are elements of our environment that capture our attention, that are salient, and that's another way in which our attention gets selective. Okay? So you can see examples of this in everyday life. Here's a kind of one that we should all be familiar with. We all know who Waldo is. He's a funny little guy with a hat and a red and white shirt and glasses. Why is it hard to find Waldo? Well, because there's lots of people. There's lots of people who have hats, and there's lots of people with red and white. And so it's really hard for us to select Waldo in this giant scene. If anyone finds it in this brief time, I will be very impressed. But I know this might nag on you a little bit, so I'm just going to give you the solution. There he is. He's right there, okay? Kudos to you if you found Waldo. You're really with it. Great. The other way we can talk about attention is divided attention. Usually this is a bad thing, I gotta say, but it's our ability to perform or divert our attention from one task to another rapidly when we have multiple sources of information in our environment. And I say we can do this, we measure it, usually not a good idea, okay? So we've all seen the example, somebody who's driving, shouldn't be doing other things, but they are. I see this all the time. when I'm trying to lecture to hundreds of students. They paid tuition, they showed up, they bought the textbook, and then I'm trying to give them some pearls of wisdom, and they'd rather be on TikTok or whatever it is people are doing these days. Dividing their attention usually does not result in a good grade. Hint to any students in the audience. The last type of attention is sustained attention or vigilance, exactly what you think it is, when you have to select your attention and stay on that thing for a long period of time. So you can think about air traffic controllers have a very boring job. Lifeguards also have to have very good vigilance. They can't let their attention slip. And in an ideal world, the prodigal student also has good vigilance and attention and is not tempted by their smartphone. Okay? So as a neuropsychologist, we measure attention in different ways. We're also interested in other parts of how we think and process information. One topic that you may or may not have heard about is something that we call working memory. It's related to attention, but it's basically our ability to take in a select bit of information and hold it in our mind. And not only that, we have to hold it in and play around with it or manipulate it. And it's these two things that take a lot of processing ability from us that comprise what we call working memory. So you can think about this. We use working memory all the time. If you're doing math in your head, you're at a restaurant, the bill comes, you're trying to decide how to split it, what percentage of the tip and all that sort of thing, that's a great example of working memory. If somebody's telling you an elaborate story and you don't know where it's going to go, they're not that great at storytelling, so they tell you a bit of this, and then they diverge and go talk about that, and you're trying to keep it all in your head. That's something where you need your working memory to make sense of what they're saying, or else you're going to lose the plot. When we test people in the clinic, we might have you do things where you take some information and move it around. So something like mental arithmetic, or I could give you some numbers and I would give you the rules and you'd have to move them around in your head and say them back to me. No writing down, no cheating. Okay? And working memory is something that we use all the time. When we usually talk about memory, I would wager most of us are thinking about what we actually call episodic memory. And episodic memory, quite simply, is our ability to retain and recall events from our own personal past. Right? The episodes of our life that comprise the sort of life story that we have. One way to think about what makes a memory episodic is it has something like a what, a where, and a when. And if you really have a good memory, you can remember the links between them. Okay? Technically, based on the scientific definition, to make a memory really episodic, it has to have a very special property or flavor or characteristic, and that is, when you recall a memory, it sort of brings you back. You have a subjective feeling that you're re-experiencing that event, and in some cases, you almost feel like you're there once again. Okay, so you can think about very important moments in your life. Your wedding day, a graduation, for a lot of us, a specific smell, right? So if you're trying to sell your house, bake fresh bread, you know, all those certain things. And it could be a specific site, right? So for those of you from the area, you might have heard that the Boblo Island sign on the other side is getting torn down, and that caused a lot of grief for a lot of people because that sign meant something. It brought people back to a certain time. So what we do, we don't ask you your life story in the clinic. We usually just give you a boring list of words, like a grocery list, or we might give you some pictures and ask you to remember them and see how well you do. In addition to the events that we have in our life that we hold on to, we pick up a whole bunch of other different information over time. And one type of information is what we call semantic memory. Very straightforward, semantic memory is general knowledge. It's the stuff you learn in school. It's the things that you pick up over time when you read, when you listen to the news, right? Because they are semantics. And these bits of information aren't usually tied to a specific event like your wedding day or anything like that. They're just general facts that float around in your head, And these are the ability to pick up and use information that you've learned is closely tied to language. Because if you think about it, our ability to pick up information and hold on to it is really useful if we can transmit that information to other people, let's say our offspring. And so we pass down information over generations. And that's kind of what semantic memory is for. So even simple things like what's the capital of Colombia, or is a cantaloupe bigger than a grapefruit, typical grapefruit, these are what we would call semantic memory. Okay? Language is pretty straightforward, but you can think of language as having two basic components. One is the ability to efficiently produce or express language, and that could be the actual motor movements of moving your mouth, moving your body to convey information. But it can also be our ability to take in words, sentences, paragraphs, and understand what's being said. So the receptive or the comprehensive aspect of language. So in the clinic, we might ask you to do some things like, oh, think of these words as fast as you can, or we might give you some pictures of objects and say, what is this called? What is that called? And they go in order from like pretty everyday items to more rare, not very common items. Or we might give you a little story or show you a complex picture and ask you, well, what does this really mean? What was the moral of the story, or things like that? If you really need an in-depth language assessment, you should definitely go see a speech-language pathologist, because this is really their bag. They really enjoy dissecting language to the nth degree, and they can be very helpful. Kind of other side to the auditory or sort of verbal side is the visual spatial side. So we not only converse with other people, but we move around in our environment. And so our visual spatial ability is the extent to which we can accurately perceive objects, perceive their attributes, and how things are in relation to one another. Okay? So we can assess this quite easily by just having people draw simpler, complex pictures, or have some sort of puzzle where you have to put things together in a certain order. Or we might give you some things like lines and ask you to judge the relative orientation. And the last thing I'm going to talk about is a complex topic, but one that's particularly important for people who have kind of Parkinson's or Parkinson's syndrome, and that's something that we call executive functioning. And executive functioning is a big umbrella term for a whole bunch of different abilities. But the key factor that underlies all these abilities is our ability to control our behavior based on a current goal. Okay? So if we lived our lives the exact same one day to the next, if we got up at the same time, if we walked downstairs, if we had the same thing for breakfast, sat in the same spot, and did the exact same thing day in and day out, we wouldn't need our executive functioning at all, because it would be routine. Everything would be exactly the same, and we could predict it. Unfortunately, our lives don't always work out that way, and there's plenty of curveballs we're thrown along the way. And executive functioning are the skills that allow us to adapt to a changing life. So for example, if you have to take in new information and keep updating what's in your mind on the go or on the fly. So if we go back to that example of someone telling a very long and drawn out and labyrinthine story that doesn't seem to go anywhere and is difficult to follow, you're always trying to take in the new information and link it to what you were already thinking of and things like that. It's a lot to sort of do. Another thing that's part of executive functioning is switching rapidly between doing multiple things. Another facet that's very important for executive functioning is our ability to stop an automatic behavior. Okay? So if you want an example of this, we often have these sort of routine things that we do. If you have a smartphone or an iPad or something, you're used to having certain icons be in certain parts on the screen. And then what happens every 6 months or so, they change or they update it or whatever they do, and all of a sudden, Where's the internet browser icon? It's moved. Or the screen, the drop-down menu isn't where it used to be, or they don't even have a drop-down menu anymore. What do you have to do? You pick up your phone, you turn it on, and you have to stop yourself and say, nope, it's not there anymore. I don't remember where it is exactly, but it's somewhere else. And that takes a little bit of time. And so that requires, again, executive functioning. Other things like planning and making decisions that require you to integrate or weigh the pros and cons, the pluses and minuses of the different options that you have. These are great examples of what we call executive functioning. Okay? Now, I know I talked about these things in the abstract, and I've been teaching at the university a little bit now, and sometimes things feel very abstract, and more I like things to be very concrete and simple and easy to digest, especially after lunch. So I think we should go through an example that walks through all of these different cognitive activities. Because we're in Windsor, we're going to use a local example. So let's say we're going to the Henry Ford, okay? You used to go there all the time as a kid. You haven't been there for a while for obvious reasons. Now it's time for us to go back and see things again. So let's say you wanted to plan a trip with the family. Let's say your grandkids are going or something like that. So you want to go to the Henry Ford. What do? We don't just get in the car and drive there. First, you got to plan the trip. Okay, so you take a look at people's schedules. You look at one weekend. It's really great weather, nice and sunny. However, the next day on the Monday, you have a specialist appointment somewhere that's a 2-hour drive. And so you just say to yourself, okay, well, what about the next week? The next weekend, there's a 45% chance of rain, but you have nothing on the Monday. And so now you got to weigh yourself. Is it better to go on a day where I know it's sunny, but I might be tired from the trip, and that might sort of bleed into the appointment? I might not be in great shape. Or is it better to go when I don't have anything on the Monday, but we might only be able to see the indoor part of the museum? And that's a question that only you can answer. But that whole process of weighing the pros and cons would be using your executive functions. So you make a decision, you pick a date, next you got to plan what to bring, come up with a list, talk to your spouse, talk to the family. Again, that process of dealing with multiple bits of information is executive functioning, and then you got to pack the trunk. And so that whole process of where do I put this? Do I put this here? If you got young kids, do we want the cooler to be closer to the back so we can reach it if we need to? All those different things go into executive functioning. Okay, you pick the date, you pack the car, you're on the road, now you're trying to get there, okay? Obviously, when you're driving, it takes a lot of visual abilities. You have to keep an eye on the road, you have to use your attention, but you also have to judge the relative position of the different cars, not just the ones in front of you, but the ones on the side, and account for things that might be closer or farther apart than what they seem. So there's a lot of things going on when we're driving, and if you've been to the Henry Ford Museum many times, you might still remember how to get there. You might know for a fact, I take this highway, I got to head over to Dearborn, and it's something that you can recite without much difficulty. And so your semantic memory is working really hard too. Then there's the dreaded aspect of parking. So let's say it's not too busy. You get in, you drive in, you manage to find a spot. It's great that you found a spot, but now what do you have to do? You have to remember where you parked the damn car. And that can be a little tough thing to do if it's not sort of divided and if there's a lot of people. That in itself is a little episode. It's a specific where, what, and when, the what being your car. And if you fail, if you're not able to do it, you might be circling the lot for a little while, okay? You get to the car, you unload it, family's in the foyer, now you're trying to enjoy the day. You got to buy tickets, so you're speaking to the person at the ticket desk. They're telling you things, you're trying to understand, your language is going. You're trying to keep in mind the prices of things and how many people, do we have kids under 12 and things like that. Your working memory is going, okay? You got your tickets, now you're ready to go see the museum. You pick up a map, you open the map, and now you have to, again, figure out what's the best route that we're going to take. And you have to look at a reference point that doesn't look exactly like what's in front of you. So you're sort of going back and forth between different types of perspectives, what you see in front of you and what the map represents. So your visual spatial functioning is going crazy, trying to keep in mind all the goals and things and places people want to do. Things people want to do is your executive functioning and your working memory as well. Okay? And then, as a kind of final note, if you'd been there many times as a kid, but you hadn't been there in a while, at some point in time, you're walking through the museum and you stumble upon something and it immediately takes you back. Maybe it's a Model T. Maybe it's a certain specific kind of telephone that you thought was funny when you were a kid. And that might trigger something that we colloquially call reminiscing. You see that certain thing and it brings you back to a point in time when you were younger. I've only been to the Henry Ford once in recent memories, but I remember back in 2019 when I went, my son thought it was really hilarious that there was a sort of truck that was shaped like a hot dog, right? So he had never heard of the Oscar Mayer Wienermobile. It was not his generation thing, and so he thought it was hilarious. And so every time I think of the Henry Ford, I think of the Oscar Mayer Wienermobile, okay? So that's a little foray into how we break down cognition scientifically, and these definitions, these descriptions allow us to study it in the context of the complexities of everyday life, okay? So we've gone through the many dimensions of cognition. Now I'd like to go over, as a neuropsychologist, how we measure these things and how this relates to kind of Parkinson's and Parkinson's related syndromes in general. Okay? And I'll talk about two aspects briefly. One is how cognition can change over time, and the other, how cognitive assessments may be useful or helpful for management or treatment options. Okay? So what happens in a neuropsychological assessment, it's typically a long day. Right? So you sit down with someone and you'll do a series of very in-depth tests that last kind of like half a day. And we really give you the kitchen sink. We want to know, how's your attention? How's your vision? How's your language? How's your memory? And so we kind of put you through the ringer a bit, but the sort of benefit of this is you get a very good picture of how you're doing in your different cognitive skills. Okay? And what we do is we combine our understanding of cognition with our understanding of the brain. And as a clinician, it's our job and sort of expertise to account for things that make people different from one another. So for example, some people might be a bit older, some people might be a bit younger. There are some cognitive things that change between males and females. What kind of thing did you do for work? How long were you in school? What kind of medical history do you have? Do you speak multiple languages? All of these things have to be taken into consideration to give you a good picture of how your cognition is at any given time. Okay? And what we do, and kind of one of the most useful aspects of a neuropsychological assessment, is we don't just say like, you remembered 4 things. That seems pretty good. What we like to do is we like to have as accurate a measurement as possible. So one thing we do is we compare your performance on these tests to people, a large group of people who are about your age. Okay? And in this way, we get a sense of where you stand and what we would expect. Okay? So you might have heard of something called the bell curve. This is just a way of describing any sort of measurement where you have a lot of people. So it could be height, it could be weight, it could be how far you can throw a football. Okay? And the sort of key here in a bell curve is that most people kind of fall in the middle, and that's, we say, is kind of within expectations. Some people a little better, some people a little worse. Some people do a lot better, and some people have a lot of difficulty. And those are the sorts of things that we sort of keep in mind. If you have kids or grandkids, you might remember something very similar when they were young. When you bring them to the doctor every so often and they measure their height, they measure their head circumference, and they compare those scores on a growth chart, which is the exact same idea, right? So we want to know, is this child growing at a rate that's relatively comparable to most kids their age? It's the same sort of idea. Okay? And why is this important? Well, it's important because neuropsychologists in general, One of the things that we do a lot with patients who have some sort of neurological condition is we measure their cognition at certain points in time, and this can be particularly helpful to identify whether there's an issue, and if there isn't or there is, how that's changed over time. And to do so, we need to account for things like age, level of education, et cetera. Okay? And the reason that this is important is because, as we all know, if you have 100 people in the room who have Parkinson's disorder, you have 100 different patients who have Parkinson's disorder. It's a very variable kind of condition. And so it's not the case that if you have a condition like Parkinson's, everyone is going to look the same, and everyone is going to behave the same, and everyone is going to change the same. Right? And so this is a challenge for clinicians to sort of diagnose and manage conditions as they occur over time. And it's still an area of active research. So if you look at people who are initially diagnosed with Parkinson's disorder, depending on how you define it, around 15 to 25% will have some mild issues. What do I mean by mild issues? Mild issues means there's some change in your memory or in your attention or your executive functioning that's a little bit worse than what we would expect, but it's not so bad that you're not able to live on your own or to do things by yourself because of cognition. Okay, there might be motor issues at play, but we're just talking about cognition over time right now. Of those individuals, around 9 to 15% would decline each year to something that we call dementia, which means that there's a point in time in which your cognition changes in at least 2 areas, the 2 that I talked about, and they get worse to the point where you're going to start to need help with things, like managing the finances, keeping track of what your appointments are, remembering what to buy at the grocery store, and things like that. But this is still a very active area of research, and there's a lot of sort of back and forth because it depends on what you call sort of impaired. And so this is a very active area, and we're talking here about a percentage of a percentage. So what this means is, it's not the case that once you get Parkinson's, you're automatically going to have these issues right away. But at some point in time, you might encounter some of these issues, in which case an assessment might be helpful. So to sort of sum this up, some patients will experience some cognitive changes, some will get worse over time, but if I had to tell you, there's no predictor right now that says you're going to have a lot of trouble with your memory 10 years from now. We don't have that for anything, to be honest. And so at some point, if people are starting to notice things, it can be very helpful to get an assessment. And so that's why I'm kind of here. And so that's the utility, is to sort of give you an accurate picture of how you're doing. And if you're being assessed more than once, to see, has there been a change in certain parts of your cognition over time. Okay? What we give you is a profile, and we can use that profile to sort of track and manage things in consultation with someone like your neurologist or your family doctor or your psychiatrist or something like that. Okay? Another very important use for having an in-depth neuropsychological assessment is there are certain treatment options that might be available to certain individuals with Parkinson's, but they require that someone doesn't have something like a dementia. So a good example of this is deep brain stimulation. So I'm sure you've all heard, there are some people who are good candidates for this, where they neurosurgically implant an electrode in the brain that stimulates deep within the midbrain to help alleviate some of the motor symptoms, which is an incredible sort of treatment option. However, if you are already having a lot of cognitive difficulties, the concern is if you go and have this very invasive and major surgery on your brain, that's going to tip your cognition over, and you'll have a lot more difficulty with remembering things and doing things to function in everyday life. And so a cognitive assessment is actually necessary to determine whether you're a good candidate for that kind of treatment. Okay? So I just wanted to kind of bring that to your attention. So I know maybe I sort of breezed through that a little bit, but I want to just take a second to sort of digest and summarize things. So there are different aspects of cognition. They're important in everyday life. And at some point, some individuals with Parkinson's might experience some cognitive changes. And at that point, it might be helpful to go talk to your doctor. And if he or she thinks it's relevant, to go get a referral to see a neuropsychologist like myself. So that's the more practical side that's kind of, I wanted to talk to you about first. Now I kind of want to share a little bit of the research with you, because at the university we do research, so why not share it with the people who are, have a vested interest in what this research tells them right from the outset. So I'm going to talk about two things. One is Parkinson's syndrome and what I'll call perceptions of cognition, and then the other is what I'll refer to as remote cognitive assessment. Okay? So here's the first thing that's new about cognition and Parkinson's. One of the things you might realize is that you probably have never heard of a neuropsychologist until today, or maybe you read about it or something. One of the reasons for this is we don't usually test people's cognition routinely. It's not like getting a prostate exam or a mammogram or even checking for cavities. By and large, if you don't notice anything, we assume it's fine. It's not actually that useful to just give people memory tests all the time if they don't need it. So what we do instead is we rely on people saying, I think I'm starting to notice some things, or my wife's noticing that I'm doing this and I didn't used to. And so we rely on people to come to us. Your family doctor relies on you to come to them and say, I've noticed a change. I have a concern with my cognition. We call this in the business subjective cognitive impairment. It's just a label. Don't make too much out of it. It can also be called subjective cognitive concerns or subjective cognitive decline. But the idea here is that you're telling us, hey, doc, there's something wrong. I'm not thinking quite right, but we haven't done anything to actually run a test on it. That's all that subjective means, okay? So you might get questions when you see your family doctor. How's your memory? Is it getting worse? Does it start to worry you? So that sounds like a pretty good system. Why test for things if they're not a problem, right? If it ain't broke, don't fix it. Well, as it turns out, there's another aspect of cognition that I've been saving. I haven't told you about it at all until right now, and it's called metacognition. Metacognition is our ability to think about ourselves. Wait, okay, go back. Metacognition is our ability to think about our thinking abilities. That's a really weird thing. But anytime you make a judgment about something, you're essentially thinking about how well you can do something, right? And one of the big challenges we have in psychology, in general, it doesn't matter if you have Parkinson's or not, it doesn't matter if you're young and old, man or woman. A lot of people don't realize that we're not actually that good at judging ourselves. It doesn't even matter what it is. So here's a great example. This is a study that's been replicated many times. It started in the 80s. You take 100 drivers, people who drive cars, and you say, okay, how good of a driver do you think you are? Rate yourself on a scale of 1 to 10, 5 being an average driver, 10 being like the most amazing driver, 1, you can't even drive properly, right? 75% of people will rate themselves as being a 7 or better, right? So most people think they're an above average driver. This is not possible mathematically, because you can only be an above average driver or a below average driver. It should be 50%, right? But 75% of people think that they're way better than they actually are. It's a cute example, but there's a lot of different examples where we actually don't have a good sense of how good we are. And this is metacognition. Okay, so that was interesting. How does this relate? This presents a problem for us in the clinic, because if we're relying on you to tell us if you have a problem, and people in general aren't always good at judging their own abilities, sometimes people will have concerns about things like their memory, but they're not 100% accurate. They're a little bit off. That is to say, their subjective concerns don't match their objective performance. Okay? This was an issue that was first brought up in not the Parkinson's disease literature, but in people who have Alzheimer's disease. So you can have people who have Alzheimer's disease who say, you know what, my memory's getting worse, I'm really worried about it, we're all really concerned. And as it turns out, their memory is where we would expect. It's in that kind of middle part of the bell curve. And there's different reasons for this. A major one is depression. Another one might be you're just really in tune with what's going on with the brain and what changes with age. You do a lot of reading, and so if you sort of notice something a little bit, you might think to yourself, well, maybe this is the start of something big, colloquially called in the worried well. And then there's a third psychiatric condition that we call functional cognitive disorder. So that's on the one side of things. On the flip side, there's also people who say, you know what, my memory's as good as it has always been. But it's the spouse who says, no, he was supposed to go to Sobeys or Metro and buy the turkey for Thanksgiving, and he forgot. And it totally ruined Thanksgiving dinner. There's something wrong with them. So there's the flip side where people think their memory's okay, but as it turns out, there's a big problem. And we call that diminished insight. There's a fancy word, anosognosia. And so we have this kind of chart where some people say they have a problem, and yeah, they do have a problem. Other people say, no, I'm okay, and they're okay. And what we're really concerned with is the people who are in the blue or red, people who say they have a problem and don't, and the people who don't have a problem and actually do. This presents a problem for us as clinicians because these are people who are falling between the cracks. And this problem persists in Parkinson's disease as well. So we don't know if you have Parkinson's syndrome or Parkinson's disease. You go and talk to your doctor. We don't know if you say, you know, I'm starting to notice these things. I can't predict very well whether you actually do or not without going and putting you through all these tests. And so this is a very important problem to understand because people can have Parkinson's for a long time. Cognitive changes might not come right away. And so it's important for us to be able to identify times in which there's a concern that really needs to be followed up on versus when there's a concern and it reflects something else. Okay? And so this is what kind of some of our work is done. One of the few ways we can actually solve this problem is just to look at a whole bunch of patients. And so this is what we did. This is called a chart review. This is where you take a whole bunch of patient files and you go through in great detail and you pull out as much data as you can and you essentially look for patterns. And so that's what we did. So this is based on 116 patients from Sunnybrook who have a Parkinson's syndrome. So they look like they have something that looks like Parkinson's. Sometimes it's due to Parkinson's disease, but sometimes it's due to other things like Lewy body, multiple systems atrophy, or cortical basal degeneration, or progressive supranuclear palsy. So these are different related conditions, all from Sunnybrook over the last 10 years. And these are patients who were referred to us because the neurologist saw them and said, hey, yeah, you might want to check out their memory because there's something that it might be off. So what did we do? We thought, you know what? If we really want to get to the bottom of the patients and their concerns, we should go ask the patients. We shouldn't rely on just some numbers in a chart. And so what we did do is we went through the report that was written, and the psychologist would always write in words, like in the patient's words, what their concerns were. And what we did is we made a coding scheme. So if people had a problem with attention, like being distracted or difficulty following conversations, we called that attention. We did similar things for memory and for language. If people said they were kind of confused or disoriented, we called that kind of spatial or orientation. People said they had difficulty moving quickly or thinking quickly, that was speed. And then there was a type of complaint that didn't really fit really well into the other categories, and we just called that other. So if I'm having a lot of difficulty reading, for example. And so we have all this data. What do we do with it? Well, I won't bore you with the details, but one of the things we can do is we can take all this information, and without having a prior idea, we can just throw some fancy math at it, and we can ask the question, are there meaningful patterns that emerge? That is to say, if someone complains about one thing, do they also tend to complain about a certain number of other things? So it's trying to fit a pattern to this data of just 116 different complaints. And what we're interested in is a profile. Do certain types of complaints tend to go together? And do these complaints relate to other things that we've measured? Okay? So unfortunately, these analyses spit out graphs that are not very pretty. So one factor relates to memory and attention and language. The other relates to speed and orientation. That's a little bit weird. I'm just going to put it in words for you. This x-axis, this red axis, is about people who have, say, yes, I do have a problem with my memory, or no, I don't. Okay, well, that makes sense. Or yes, I have problems with my attention, or no, I don't. This blue axis represents a different kind of pattern. There's one group of people who are complaining about being slow, and there's another set that are complaining about getting lost or disoriented or being confused. But they're different types of people. And so this is a little bit puzzling. So to make sense of this, what we can do is we can add other stuff into the mix to try and see if we can make sense of it. And so what I'm showing you is the kind of graph and plotting or putting the other stuff in. So on the sort of arrow that's going up and to the right, those are scores of something we call the MMSE, which is a general brief cognitive screen. And what you can see is it points in the direction of people who have a complaint with their memory and their attention. So what we think is, if you're complaining about your memory, you're complaining about your attention, you probably are having those issues, and that's something that we should follow up on. However, the second arrow that's pointing down are scores in what we call the Beck Depression Inventory. And so that's a questionnaire we often give for people who are feeling sad or maybe feeling a little depressed about things. And those things tended to correlate with whether people tended to be disoriented or confused. And so what we generally think now is that there's two general patterns of complaints. One has to do with general cognitive issues. Oh, my memory is not great. I can't understand people. I have trouble paying attention. Those people, it seems they actually do have some things that we should follow up on with cognitive testing. If they have complaints that have to do with being disoriented or being confused, maybe that relates more to psychiatric issues, or maybe there's a more complex picture going on. And so this is preliminary data, but it's important because if we can better characterize the types of things that tend to hang together, the idea is when you go to your family doctor and you say, I've got X, Y, and Z, they'll have a better idea of how to best serve you next. Okay? And so this is preliminary, but I think it's compelling stuff. I only have a few minutes, so I'll just jump to the punchline. I know going fast isn't a great thing in this context, but I just want to leave this with you. You're like, Chris, you sold me. I want to go get one of these fancy assessments. Where do I go? Here's where you go. Toronto, London. If you really want, you can come see me. I would wager that not all of you live in Toronto or London. And so here's the problem. Geography, as you all know, is a major barrier to getting any sort of specialist service. Okay? I don't have to convince anyone in southwestern Ontario of that. There's issues with mobility. There's issues with cost. You know, even when you get to Toronto, Park in Sunnybrook, $24, right? Not cheap. And then there's the issue of things that are specific to Parkinson's, like timing medications and all that sort of thing. So COVID rolls around, we just ask the question, can we do some of this online? There's people here online today. Can we do it online? And if we do it online, can we get something that's reasonable, or is it just spotty internet and all that sort of thing, and we can't make heads or tails of it? So I'm going to skip through a little bit. We piloted a task in 17 people from Windsor. These are community-dwelling older adults. And we gave them a memory test. I had this fun task to do, but I'll skip through it. It's a test of memory precision. So what we do is we show people pictures of objects. Okay? Pay attention to these. I'm going to ask you about them. Okay? 16 objects in total. I do something else, and then we say, this one. Is this the same thing I just showed you? Is it something that's kind of similar, or is it something completely new? Okay? Who votes for same here? We got a lot of sames. Similar? New thing? Okay, good. You're paying attention. I like it. The professor in me is happy. What about this? Is this something you saw before? A similar thing? Completely new? Okay, very good. All right, what about this one? Same? Similar? New. No one for new. Okay, it's similar. It was a teddy bear, it was a brown one, but it wasn't this one. So you can see what I mean when I say precision. Right? We give people some questionnaires that say, how bad do you think you're doing in everyday life? Are you forgetting this? Are you forgetting that? Right? And then we also give people a questionnaire of mood. We give it to them online. We collect their data. This is the ugly graph that it spits out. I will give you the punchline. As it turns out, you can test people's memory online. And it correlates. It's associated with what they say. So if you say, no, my memory's pretty good, I have a high score on this questionnaire, lo and behold, your memory on our test is pretty good. Right? The reverse is also true. So just to sum up, neuropsychological testing can be useful for individuals at a certain point in time. There's a complex pattern of cognitive concerns that can show up in Parkinson's, and maybe we can sort of manage some of these cognitive things in an online remote fashion. Okay? So I know I'm out of time, but I do have just 30 seconds to ask what's next. I talked about what's new. What could be next? Well, the way I see it, I like to dream in color. I work in a clinic. I have PhD students who need to see patients so that they can learn how to do these things. We have a wonderful group of people who have Parkinson's, some of which might need this kind of service down the road. Why can we not combine these things? So we have a clinic on the campus. I don't know if many people know it, but we see people for things like Parkinson's or multiple sclerosis or depression or things like that. And I would love to sort of form a collaboration with PSSO at some point. I don't know how, I don't know where, but my door's always open. Okay? And I do want to leave you with one thought. I am very aware I spent the last 40 minutes talking about deficits and impairments and what we can't do. And I feel like a lot of times patients get thrown this language all the time. And I want to just remind everyone that we can think about things in a different way, or a slightly more positive way. So I'll leave you with this quote by the Canadian author Robertson Davies, and I'll read it to everyone as well. You like the mind to be a neat machine, equipped to work efficiently if narrowly, and with no extra bits or useless parts. I like the mind to be a dustbin of scraps, of brilliant fabric, odd gems, worthless but fascinating curiosities, tinsel, quaint bits of carving, and a reasonable amount of healthy dirt. Shake the machine, and it goes out of order. Shake the dustbin, and it adjusts itself beautifully to its new position. Okay? Merci beaucoup. Thank you very much for your time. There's my email. There's my lab address. I'm here to take your questions.